Joining us this morning to talk a bit about the COVID vaccines and also some of the news that we are hearing in the media about Johnson & Johnson vaccine. Once again, I would say they have to be our favorite doctors from Salmon Regional Medical Center, right? And friends of the show.
Yeah.
Dr. Erin Philpott and Dr. Brad Greenberg from Salmon Regional Medical Center are on the phone with us this morning. And good morning, doctors.
Good morning. Thanks so much for having us.
Good morning.
Once again.
You bet. It's great to have you both with us. And Megan, do you want to get us started?
Sure. So let's talk Johnson & Johnson vaccine. We know that there's been a pause on its use because of blood clot concerns. There were 6 cases of blood clots. And so, Dr. Greenberg, why don't you kick us off in explaining that to us a bit more?
Absolutely. So as everyone is probably aware, the Johnson & Johnson vaccine was paused. I think it was on the 12th of April. And what had happened is that they had noticed that in the, I think, over 6.8, approximately 7 million cases of Johnson & Johnson vaccine administered, there were 6 cases reported of what's called cerebral venous sinus thrombosis in conjunction with very low levels of platelets. And so that's a pretty rare clinical entity. And so they had basically expressed some concern about that and noticed those things were going on. And there was some consideration about whether or not those particular blood clots were either reflective of what we call a background rate or really the normal rate of a rare medical problem in the population, or if they were higher because of the recent receipt of the Johnson & Johnson vaccination. So all 6 of those cases actually occurred in women between the ages of 18 and 48. And they seem to occur between 6 and 13 days after vaccination. And it's a significant clinical entity. And also there was another element to this. We do see different incidents of what we call cerebral venous sinus thrombosis. It's a rare clinical entity, but really we don't see it in conjunction with very low platelets. And so the low platelets was a new element that was added, which really changed the way that we physicians would approach this kind of problem. And so the pause was largely designed to create a little bit of space for the Advisory Committee on Immunization Practices, ACIP, to meet, and they met on the 14th of April, and also an opportunity for a little bit of education and training for physicians to make sure that we recognize this clinical entity and modified the diagnostics and the treatment associated with it as well. So I think, though, that the pause is also it's actually a very good example of how science is working. And I think that with this pause, the structure, the expert input with this, I believe that it really demonstrates the emphasis on safety for what is really a very rare clinical entity. And so I think it's a great example of the emphasis on safety and capturing every possible complication associated with the vaccine. So that's sort of the background for where we're at.
Very good. Thank you. And Dr. Philpott, I have a follow-up. I know all 6 of those cases were women, and there was some talk about how, well, birth control can also cause people to throw clots. So is this platelet, this combination of low platelet and the blood clot, is that what separates this from what normally might happen in that situation?
Yeah, Megan, that's exactly right. And that's why these cases have kind of stood out. And as Brad kind of alluded to, this was to also inform the physicians caring for these patients and be able to identify it. We see sort of a similar entity called HIT, heparin-induced thrombocytopenia. that is tied with low platelets and clots, and it looks like this may be a similar mechanism. So you develop some antibodies against platelets. Platelets are a part of our blood component that help clot. So they form clots when you cut yourself, and that's how your bleeding stops. So in some cases, when we start people on this anticoagulant, heparin, people actually develop these antibodies against these platelets. The platelet levels drop, and then they clump together and they form clots. That seems to be what's happening among these women, which, as you pointed out, is distinctive from the usual cerebral venous sinus thromboses, which typically have normal platelets. And as you can imagine, is really important when we're thinking about treating these patients. Heparin or enoxaparin are first-line medications, and those could actually make these cases worse. So it requires a different type of anticoagulation, which again, it's really, pausing this vaccine really has put everyone on high alert, meaning the medical community, the physicians, to tune in and pay attention. And that was, a huge part of the intent of the FDA and CDC to educate us all.
Very good. Thank you, Dr. Philpott. And Dr. Greenberg, I wanted to come back to you a little bit about these numbers, because I really want our audiences to understand just this very small percentage of cases that have come up. You mentioned, over 6 million doses, just 6 cases of this blood clotting problem in just women, right? No men were affected. And so can you talk a little bit about that number? And I guess the greater point maybe is that the science is kind of working as it's designed to work to be able to look at some of these very small incidents and then take a look. And I think the language saying that they're going to pause the vaccine was very deliberate, not canceling, not stopping, but pausing while we find out more about what exactly is going on. It's a very rambling question to Dr. Greenberg, but I'm hoping you followed it.
It's a great question, but I think that the real key here is that this is science working with incredibly low probability. Okay, but let's remember here, these vaccines didn't exist a year ago, and this is every single one of these clinical trials. They weren't rushed; they were rigorous and very well structured and adequately populated scientific trials. And now we're looking at these things which look like a less than 1 in a million chance. And I think that there are many things out there that will, and I think that Dr. Philpott has some numbers related to specific COVID risks as well. I don't have those in front of me, but I think that the key here is about the background rates. Like the normal background rate for things like cerebral venous sinus thrombosis, not including the low platelets or the thrombocytopenia, is somewhere around between 2 and 15 per million. This is already a super rare entity. And so, what we're seeing is, for, say, 6 cases in 7 million, that the rates of this particular clinical entity might be a little bit higher with the Johnson & Johnson vaccine. Hence all of the concern, hence the reasons to do the pause. But these numbers are incredibly low, incredibly low. You have a much higher risk of, say, contracting COVID and contracting severe COVID, and being hospitalized or dying from this than you would having any kind of vaccine reaction of this particular magnitude. I think there's many things where the probabilities for bad things happening to us as you're walking around the world are higher than 1 in a million.
Well, I agree with that. And I think there's been a lot of conversations about, just driving to get your COVID vaccine. You have a better chance of being injured or hurt than anything from the vaccine.
So, yeah, and so let's broaden out to vaccines in general. Now we're in the last phase, which means everybody's 16 and older. There might be some parents out there, maybe that have trepidation about vaccinating their adolescents. Can you guys speak to that? Some lingering nervousness that's going on? Dr. Philpott, why don't you take it?
Sure, I'll just follow up. I think Brad was making some really good points there about just sort of the risk and the risk tolerance and the possibility or probability of experiencing some of these different side effects or events associated with the vaccines. I think we've been actually remarkably lucky. I don't know if lucky is the right word, but with the mRNA vaccine platforms, we really haven't seen any standout events after vaccinating millions, hundreds of millions of people to date, which is just incredible with such a highly efficacious vaccine. So I think it's been very reassuring. I think these little sort of hiccups or pauses with the AstraZeneca and the Johnson & Johnson, again, are very appropriate. And this is what we're pausing for, 1 in a million cases of this stuff. So we're on a really positive track of evidence for safety at this point. I think comparing sort of these possible side effects versus the possibility of individual risk and death from COVID. I mean, COVID alone increases your risk of thrombus or clot formation. To agree that, I don't have a number in front of me, but I would say is likely much higher than 1 in a million based on my experience of caring for hundreds, probably thousands now of COVID cases over the last year. The infection fatality ratio, which is what Brad was just mentioning, for the age group, like to think about the Johnson & Johnson clot risk of 1 in a million, 18 to 49 age group, and this is males and females, it's 150 people per a million. So we've already had over 1 million people die from COVID. I mean, 500,000 of people die from COVID in the U.S. to date. So I think it feels, the decision feels evident. I mean, these are incredibly effective vaccines with very minimal risk associated as vetted to date by all our studies and the large population vaccinated. I think the other thing that Brad and I have talked much about is these evolving variants. And, we can be in a very different situation, a worse one, a year from now, if we don't as a collective get on board and really highly consider these vaccines and developing protection along with all our usual public health measures like social distancing, mask wearing, avoiding big crowds, because it's just the natural course of viruses to evolve, and they will evolve, and they could evolve to start significantly impacting children and kind of outwit us and evade our vaccines. So I think for individuals, there's not a lot of question in my mind of the risk benefit of getting really any of the approved vaccines to date. And then on, sort of the social contract or working as a collective to get our society back to some semblance of normal, I think it's really important.
Indeed. Go ahead, Dr. Greenberg, you bet.
I was hoping to add on to that too. I definitely echo Dr. Philpott's comments also. I have one interesting side note about the vaccine platform, and then which is basically that the AstraZeneca, which went through a whole series of pauses in the EU, and there are sort of variable kind of acceptance with the different countries around the world. Had a similar issue with blood clots, and I think what's very interesting, people are concerned. Oh, well, this is the platform they're using. This is the attenuated adenovirus. But actually, like in Johnson & Johnson has other adenovirus platforms that are used. For example, like the Ebola vaccine is an adenovirus platform. There is no cerebral venous sinus thrombosis with thrombocytopenia or low platelets or otherwise with those other platforms. So this isn't about the adenovirus. I'm excited to see how the science develops. The other component that I wanted to mention is that the other vaccines, I think Johnson & Johnson is safe. But if you want some really good numbers to feel good about if you're on the fence, is that Pfizer and Moderna have had much larger numbers thus far. And these complications didn't show up in the real world. What we say by that is that you do smaller numbers associated with clinical trials and whatnot. And then the vaccines go out. And, we've had in the United States, 97 million doses of Pfizer and 84 million doses of Moderna. And these complications were not apparent. So these vaccinations are safe. And so I think that it's very, very important that people feel comfortable with it. But also, I think the evidence, what we've seen is that these vaccines, in addition to being safe, they work. And, the breakthrough rates that we have for post-vaccinated cases are very modest and entirely expected. And I think that it's really, really important that anyone I would say thank you to anyone who's received their vaccinations and to anyone who's on the fence. It is the right thing to do. It's the right thing to do for you, for your family, for your loved ones, and it is the right thing to do for us all together as a society to try to navigate our way out of the pandemic. So I would strongly encourage anyone who is on the fence to first get their questions answered from a source that they trust, and then make that appointment and go get vaccinated.
Very good. Very good. Agreed. And just one quick clarifying question, Dr. Greenberg, the adenovirus, can you give a brief explanation about what that is?
Sure. So there are many viruses out there that basically can cause infection. And one of the challenges associated with delivering or making a vaccine work is how to deliver the right kind of material that would generate an immune response to the target cells. And so the mRNA platform, we could, as you guys like to say, we could really nerd out about vaccine delivery platforms right now. But the mRNA platform uses a specific lipid nanomolecule, which then basically attaches to the outside of a membrane, which then delivers the mRNA to the inside of the cell, where then we are able to produce the spike protein, and that causes an immune response. The adenovirus vectors use actually an attenuated virus. So it's a live attenuated virus that delivers that content into the cell as well. So it's really a different mechanism to deliver the same kind of, we would say, immunogenic antigen. So the same kind of material that causes an immune response. So that's what the adenovirus is used for.
Very interesting. Thank you very much, Dr. Greenberg. Dr. Philpott, as we kind of wrap up our conversation this morning, I wanted to ask you, and Dr. Greenberg, feel free to chime in as well a little bit about herd immunity. We've talked about that before. Now as vaccines are rolling out, and, we just talked about this a few minutes ago of how important it is to, if we want to get back to doing some of the things we consider normal, like graduations and family reunions and flying and visiting and travel and all those different things. We keep hearing about herd immunity, and it sounds to me, unless all of us get the vaccine, or as many of us that can get it as is possible, we're not going to be able to get to herd immunity. And so this may be something that we deal with year in and year out, like a flu vaccine or things along that line. So I guess the question, Dr. Philpott, is, encouraging folks to get the vaccine when they're able to, and get as close to that herd immunity, correct?
Yeah, that's absolutely right, Scott. I think, early on, we calculate the herd immunity based on sort of the transmissibility of a disease. So we use this R0 factor. So if a single person can infect 2 to 3 people, which was kind of the initially thought sort of rate of transmission of COVID, then you need about 66% of people, or 2/3 of the population, vaccinated to achieve herd immunity. I think all bets are off at this point at what number we achieve herd immunity with the more transmissible strains like the 117 and the P2 strain and the various variants. It's a little bit more difficult, but I think the bottom line is exactly as you said, as many vaccinated people as possible is how we're going to get protection. We're not going to achieve this with natural infection alone, without just really a lot of unnecessary deaths. So I think, yes, everyone who can should hopefully be able to get out there and get vaccinated.
Very good. And Dr. Greenberg, you have anything to add?
I think that I would characterize it as right now we are in a race. And I want everyone to hear that there is a specific urgency to getting vaccinated now. And the thing is that the longer that the virus is able to get out there and to replicate in any given person or host, the more likely it is that variants of concern, which include all the ones that Dr. Philpott mentioned, we try not to link them to geographic areas, and we do the numbers, but we're talking about the same thing. But the thing is that it's not like something exotic happened in South Africa, because there's a variant of concern from California. There's variants of concern that can evolve anywhere that there's the opportunity for the virus to replicate in a given host. And so what we need to do collectively, is get vaccinated and use COVID-safe practices to reduce the likelihood of additional variants of concern and to reduce the likelihood of transmission of variants of concern that are already documented. In those places where people are more vaccinated, when they've done surveillance, breakthrough cases and resurgent clusters are largely from variants of concern. And so where they've done studies like this, for example, in Israel, they've really found it's the B1351, that's the Brazilian variant, or the South Africa variant, which is the B1351. Oh, my apologies. The South Africa variant. So the variants are really the ones that are causing the problems. But unless we all get on board here with this vaccination process and we stick to these COVID-safe practices, I know it's been a long time. I know it's been challenging. I know that it's frustrating. We all want to get back to normal. But normal is not going to happen unless we all stick together and work as a one big team, one big group to try to get out of this. And this is a different challenge. This is a global problem. It's a national problem, and it's a local problem. But it's a problem that we're all in the same big community. So please get vaccinated, and we can all get out of this together.
Very good. Agreed over here. Well, thank you, Dr. Philpott, Dr. Greenberg. Thanks so much for coming on. As always, we appreciate your time.
Thanks so much. Have a great day.